Professor Coleman, thank you very much for giving us time to talk about the talk you've given at National Cancer Research Institute. Bisphosphonates.
Yep.
Tell me, what's the hottest stuff? There's a lot of interest in Berlin in adjuvant zoledronic acid, and there's a new drug called denosumab or something. Is this really new, or is it just trend?
Well, I think there are a number of new strands to this story. I think we're just scraping the surface of the biology that's going on in the bone microenvironment that these agents can affect. They started life as supportive care drugs to prevent pain and fractures, and that's very important. But what we're much more interested in now is whether they have an effect on the whole metastatic process, modify the bone microenvironment, affect that interaction between stem cells and tumour cells and the hemopoietic stem cell niche and the dormancy problem that we see in cancer, and can actually prevent recurrence.
You know, I tested some of these drugs when I was in Amsterdam in the 80s.
Yeah.
And even then they said there's an anti-cancer effect, which I have to say we arrogant medical oncologists discarded. Couldn't possibly work. But some of the data that you guys were presenting in Berlin and today is talking about the action being via extracellular mechanisms, via stromal cells, and maybe not necessarily causing breast cancer cells in the bone marrow to apoptose in a direct fashion. Maybe that's why we missed the effect.
Yeah, I think these drugs are not anti-cancer agents in their own right.
Yeah.
They will not kill an established liver metastasis. But what they do is have this profound effect on bone cell function. And bone cells not only obviously control bone metabolism, but they have effects on stem cells, normal stem cells, and possibly on the interaction between these normal stem cells and tumour cells.
Normal stem cells of the bone or normal stem cells of the breast?
Normal stem cells of the bone marrow, so endothelial
Right.
and hemopoietic stem cells.
Okay. And what's the evidence for that?
Well, there's a number of animal model studies and molecular trafficking studies which suggest that these stem cells act almost like chaperones to the tumour cell, that the tumour cell just can't quite establish the metastasis on its own, needs help.
Without the dependence of the compartment.
Yeah. We focused on killing cancer cells, and that's very important. We've done very little about thinking about the host, the soil, as was postulated over 100 years ago by Paget.
Well, only yesterday Larry Norton was giving a bit of strength to your notion, because he was talking about cells seeding and then reseeding back again.
Yes.
And that's quite interesting. You were asked today about the possible mechanism by which a drug targeting bone could possibly have an effect on soft tissue.
Yeah, that's right. I mean, again, I don't think that's a direct effect.
No.
I think if it's a true effect, and we've only seen one study that was really properly designed to look at that. So if that is a true effect, then I think you have to postulate that it's affecting the movement of malignant cells from the bone marrow environment to the liver or back to the local regional area or to the lung, rather than affecting the tumours in situ.
So adjuvant zoledronic acid. One study looks interesting, can't be ignored. The Dr. Hadji from Germany was saying in Berlin on eCancer TV that the time for maybe adjuvant zoledronic acid had arrived. Is that accepted? I think the guidelines in Germany may be pointing this direction already.
I wouldn't fully subscribe to that view. I think that's a little premature. There may be other reasons to give a bisphosphonate, bone loss from treatment, but as a pure adjuvant agent, I think we need the results of the ongoing large adjuvant trials. There's a big American study we'll report in the next 12 months with clodronate. There's my own study, Azure, with zoledronic acid, and others are working in this area, not only in breast, but in prostate and other tumours. So I think we just need to be a little bit patient. It might all unravel. This whole story may not hold together, but it's looking very promising. Of course, beyond bisphosphonates, we have a whole host of other agents which affect the bone microenvironment. Some specifically developed, like denosumab, others being developed as cancer agents, SRC inhibitors, proteasome inhibitors. We know what they do to the tumour, but they also have profound effects on bone cell function as well. So there may be many strings to this.
Clever ways of monitoring this. You see any imaging coming over the horizon, PET MR, or with clever probes? I mean, if this drug can find osteoclasts in the bone marrow, surely we can find a labeled substance that can go in there and help you monitor what you're doing.
I don't know about in the clinic, but certainly in animal models, one can now look at individual cells trafficking into the bone microenvironment. Obviously, you can make them fluoresce. You can do this in sort of cine, continuous mode, and look at not only the chemical interactions, but the spatial interactions with the host cells. So that work's just beginning. I think that's very exciting. Whether you could do something similar with PET in a patient, I'm not sure. Sounds a bit fanciful.
It would make life easier in terms of
it would, yeah.
of watching what's going on. Good luck with your research, both preclinical and clinical, and we'll await eagerly the outcome of your study, which would be next year, I suppose.
It should be. Thank you.
Thanks very much indeed, Bob.
Thank you.